Hello, this is Fernando Gomez Sancha, and here I am presenting another video on a redo case after previous TURP. And it is an interesting case because the plane is quite difficult to follow, and I think it shows how one can, chase the plane and try to correct a previously wrong plane to try to keep in a good plane and remove the adenoma completely. Here, I have to say that I have received a lot of letters and tweets and messages and everything from many urologists around the world who are appreciating these videos and the advice that they contain. And so, I thought, my job was done, showing the basics of HoLEP and all these examples. But they asked me to keep posting videos, and of course I have to find the time, which is not so difficult, not so easy. Sorry. But here I saved this case because I thought it was quite interesting, and I hope you enjoy it. Okay, so in the redo cases, you always have the impression that there is some areas that are properly resected, and then some remaining fragments or adenomeric residual tissue that has to be removed. But and I guess if you were going to treat this with another TURP, for example, you would resect the bulging pieces of tissue, and you would not probably resect so much in the areas where the previous resection seems to be good and complete. But nearly always, I would say always, and I have seen a case after open prostatectomy where there was only a big nodule hanging from the bladder neck, and the fossa was perfect. And I didn't try to look for the plane because it was absolutely obvious that there was no adenoma left inside the fossa, just in the bladder neck and let's say median lobe growth. In every redo case, I do the white line, and I try to look for a circumferential liberation, because even in the areas that looked as if they were resected properly, there is always residual tissue. So I go for a circumferential removal of the adenoma. Here you can see how I entered, the classic way, the normal way. Entered one side of the veru, firing a little bit against the floor of the veru, and then connect in the midline. You see, there is not much tissue there, but there is tissue. Okay, so if you think that this patient is going to have his second operation, maybe it's nice to try to make it the last. So that's then the development of the posterior line. Here you see I'm not looking anymore for a beautiful plane, because I think it's very painful when you try to recognize a beautiful plane. It's very painful because not always you can find a beautiful plane, and not always you can keep seeing it, because with these new enhanced newer generation lasers, even if you are in the beautiful plane, most of the times the energy is going to obliterate this beautiful aspect of the plane. So we have to start thinking, I think, and I think the mentality is probably less frustrating, that we need to look for a capsular plane. And a capsular plane is a plane that looks fibrous, that looks relatively smooth, that is mainly white in color, because the adenomatous component is usually a little bit more yellow than the proper capsule. And here you can see that this is a nodular prostate. You start to see that if you want to get all these nodules out, you will have to dig a little bit deeper, no? So as I was saying, we try to look for a capsular plane. Also, the capsular plane is sometimes not easy to recognize, and specifically if you look at a single frame, if we stop the video in one moment and we look at a photo, it's very, very difficult to say this is capsule and this is adenoma. Many times you see that's the yellow aspect of the adenoma. That's why I'm pointing the fiber outwards to see if I can find, the capsule external to these nodules, which is not easy. You notice that in order to keep oriented, instead of digging deep in one small, line in the adenoma, I always try to do broad lines. Okay, so here this was the ascending dissection towards 12 o'clock, and in this side it was a little bit tricky because we found these yellow nodules stuck to the external capsule, and it was a little bit tricky to find them. But if you want to avoid getting lost, in this, we have to carry these long lines. You see, the movements are usually quite broad, in order to try to develop lines that we can recognize, lines that are, let's say, unique, so only one line, not many, and try to connect always these lines, around the prostate, so we can have a nice reference system. So here now, this would be the start of the ascending dissection towards 12 o'clock. I always start by deepening the white line. Deepening the white line is going to open that tissue like a book, and typically the plane is going to be in the external page of that book, if I am making myself understood. But here you see, sometimes you doubt, is this a good plane or not? So carefully you try to develop the line of dissection, and we are always revisiting, we're always questioning what is the proper plane. So here I'm not knowing for sure. Okay, so I'm looking for the white, fibrous, smooth plane. Of course, I follow the steps of the operation. We always cut the apical attachments first, because if you try to go up, having the scope inside, you might be putting traction on the sphincter. So here, you see, here I was not very convinced that this was a good plane. But still, I was trying to do a relatively organized line. But you see, there's more tissue there. There you can see there's a nodule. So it was a little bit tricky. Of course, these prostates have already undergone surgery and probably some more inflammation. Sometimes, sometimes planes are not so friendly, and the only way you can defend yourself is to try to investigate if the depth is enough or not. Here, you see, we're starting to connect or to finalize the apical dissection, but when we cut the tissue, it's not very convincingly smooth, convincingly white, convincingly capsular. You see there, we see that there is a nodule. So we always have to investigate, and of course, trying to use a smooth effect of the energy in the tissue so that it dissects a little bit. It doesn't go extremely deep. I think in this moment, or probably near, there's going to be a little bit of fat visible. And when we see fat, of course, we need to correct the plane. Here I was trying to, also you see I'm going deeper anteriorly than the ascending line from the left side of the patient was showing. You see, so here again, we are correcting. You see, the plane that I was following was much under what I'm following now. So there's always room for correction, and you have to be ready to investigate. That's the fat I was mentioning. So probably that was going a little bit deep. So we will keep that in mind. Of course, if you see a small perforation, and this is the idea, if we're going to see a perforation, it has to be small. You know, the fiber measures 0.5 millimeter. So what we're going to do is to choose a little bit less depth, correct our dissection plane, and usually there is not so much danger in a very small perforation. Here you can see clearly how the plane is correcting itself. There we are. You see that's a little bit of fat visible, probably millimetric small perforation. So we're going to continue always trying to move slowly, always trying to develop a proper line. Here again, you see the plane that we are taking from above coming down is not, it's deeper than the one we had. So we try to connect the lines, try to understand better. It's sometimes tricky, and we have to try to, you see, connect the lines and try to see what plane is more convincing. If you are investigating a plane that is going a little bit deep and you find, you know, that you're coming out of the capsule, then of course we have to correct. But using the energy with a soft effect, you see that I don't try to be excessively aggressive dissecting the plane. I want to do several passes, and each pass is doing a little bit, so that allows us to understand a little bit better how things work. You know, here that's anterior. I'm trying to keep a little bit lower than the little perforation we saw there to try to develop a safer plane. But you see, my obsession is always trying to connect with the lines around it so that we can have a broader line of dissection. There you see that we are trying to understand. That's the deeper anterior line that we were developing. So I'm going to follow that path because, of course, you want to remove the whole adenoma. Sometimes it's very sticky, and it's very interesting, you know, this idea of the plane. This idea of the plane. Because we cannot always recognize what is capsule and what is adenoma. We have some features that we have discussed before, like the whiteness, the fibrosity, the uniformity of the plane. You see, when you see the capsule, it has to look uniform. But also, we have to use our already the anatomical knowledge we have about the shape of the adenoma in relation to the capsule. If you look at MRIs, pay some time looking at them and look at the transverse sections because it helps a lot when you combine, let's say, what you see here. You can see this is nodular again, you see, so we have to be revisiting the plane all the time. But as I was saying, we know the features of the capsular plane, but we also have to have some other information. For example, as I said, when you see a photogram, you don't recognize what is capsule and adenoma. Luckily, we have memory, and we remember the previous photograms, and of course, that can help, you know, getting the idea of how the plane is going. We can predict how the lines are going to go, more or less. So if you're going up in this direction on the right plane of the patient, of course you know that the line is going to start correcting itself as you get anterior, you know. So the recognition of the plane is not based only on what you see, it is based also in what you already know about the anatomy of the prostate. The lines have to be coherent, you know. If we have a nice depth in the posterior line and then we connect this line to the lateral line, you know, it has to make sense. And of course, often we're going to penetrate a little bit in the capsule, and we're going to see small perforations. And I usually say that small perforations are allowed, in the sense that sometimes in difficult cases like this they're inevitable, but we don't want to make them big. Okay, so we use the energy carefully to prevent doing big perforations. If we start to see that we're coming out of the capsule, then we have to correct before it's, let's say, too bad or too late. But also, there's this concept that the peripheral zone of the prostate has no important function. You know what I mean? That we don't have to preserve the peripheral zone perfectly in every case, you know, because of course there's people who think that when you deepen in the capsular plane, you know, when you're going a little bit extra anatomic, maybe there is a little bit more discomfort postoperatively, or, you know, but the truth is that often we follow a capsular plane that is maybe not exactly the best anatomical plane. And what I'm trying to say is that this is not the end of the world. We might be taking some of the peripheral zone with the adenoma in some areas, so we are deepening. But if you are not outside, if you're not perforating, it doesn't really matter that much. It's not going to compromise, I think, a good result postoperatively. And of course, many times we don't have the ideal prostate. We have, let's say, the difficult planes or the inflammatory prostate, or so we have to get used to this concept. No, we look for a capsular plane. Not always it's going to be beautiful. We need to do these broad movements to carry very nice lines that will allow us to understand a little bit better where is the limit between, you know, prostate and adenoma, and of course, yeah, this will allow us to finish even the difficult cases. Okay, so here you see now how we have this circumferential line around the prostate. I think now we have found a relatively, you know, good, satisfactory plane. Some people are not so happy to remove these nodules. I think these nodules have a potential to grow fast after the operation if you leave them in situ, you know. So I tend to take them out always, even when they're close to the sphincter. I tend to be aggressive and try to remove all the BPH tissue, and maybe sometimes a little bit more, you know, because of course when you have a very beautiful plane and you can recognize it very nicely, it's nice to be there. It's nice to follow the perfect anatomical plane. But here we had a hint that we were in a very nice depth for a moment. Here also you see that's probably the good anatomical plane, and the depth that we are following, the line we are following, is coherent with this depth. So probably we are okay, and there we are progressing around until we can start seeing the sign that we are going to enter the bladder neck. So yeah, this is it's incredible how, you know, we are surgeons, we do an operation, and then we look for these philosophical concepts, no, that helped us, I don't know, understand better or adapt better to the singularity of each case. You see, that's the clear entry into the bladder at 12 o'clock on top of the anterior commissure. So now the rest of the case is going to be quite standard, I think. But yeah, I think if you look for a beautiful plane, you will be frustrated many times because you cannot find it. You cannot find it all the way around the prostate. You cannot find it. Maybe you see a good plane posteriorly but not anteriorly, or vice versa. You know, there's a lot of variability. And then it is paramount to work slowly. You see that the movement of my scope is like in slow motion. It's always calm and relaxed. I think the speed in HoLEP comes with the ability of working continuously rather than the speed of what you do. So you can go slowly, and if everything you do has a purpose and has a reason and is effective, if you use the energy to dissect, or if you stop for a moment to coagulate, these are effective maneuvers. So that will make the procedure relatively fast. We're now 20 minutes inside the procedure. You see that the line circumferentially surrounds the adenoma. We have a satisfactory plane now, and that's a little bit of hemostasis because you don't want to accumulate too many vessels bleeding at the same time. So there we are, trying to follow this line again. You see, we follow this line. We try to connect with what we had on the other side. And there we are, you see, coming around the adenoma. Again, that's a nodule. You see that? Many times you can see that's a nodule. You see, you see this line that goes around it. You see the color. So sometimes we had to dig a little bit deeper to try to remove these nodules. These nodules usually grow into the capsule, and they make the capsule much thinner. So that's why some people are a little bit afraid of removing them. You see the nodule? So in these cases, you have to use your knowledge of the basic way to use the fiber, to use the energy. The settings of the laser are defining how the energy is coming out of the fiber, but it is the surgeon who decides how the energy reaches the tissue, which means that depending on the working distance, depending on the speed of movement, and also depending on where you target the energy, you're going to have different tissue effects. And obviously, when you have a thin capsule, or when you are working closer to the bladder neck, the capsule tends to be a little bit more perpendicular to the fiber. So you have to start firing a little bit closer to the adenoma, to the edge of the adenoma. Okay, we follow the line, but instead of firing against the line, because in this case you see the energy might go directly into the capsule, you need to keep close to the border, close to the side of the adenoma, you see, and then you are able to cut the attachments of the adenoma with the capsule, but only some coagulation, takes place in the capsule. We're not using the energy in a way that the disruption can cause deep perforation. If you go a little bit deeper in the capsule, if you recognize that you are starting to enter the capsule, then you have to correct, you have to fire even closer to the adenoma, so that the energy, as you can see there, usually in the posterior plane, we have to keep the energy anterior. So if you identify the line, which with two planes, the capsular plane and the adenomatous plane, it's like always firing against the open, the line formed by the pages of an open book, And what I'm saying is, instead of firing against the line, you fire in the upper page, on the upper page side. That will keep the energy close to the adenoma. That will not penetrate in the capsule, and it will allow you to dissect these planes even when the capsule is totally perpendicular to the fiber. The energy will be used to cut the fibers that you join or attach, you see, the adenoma to the capsule, but there will be very little energy hitting the capsule with enough ability to cut it or open it or perforate it. So these three factors, the working distance, the speed at which you move the fiber along the line, and the targeting in relation to the line of dissection are the factors that will allow you to use the energy. Here, for example, is very obvious. I'm firing more closer to the adenoma than the line, you see, and I try to keep there because that will help me dissect and carefully separate adenoma from capsule. So you see, if you are calm, if you move slowly, if you are ready to correct your targeting, you know, depending on what you see and the depth of the tissue, you can safely develop these planes. You can safely even explore. That's another nodule, you see. I'm going out a little bit more now because I want to go deeper and remove this nodule. But of course, I have to use a very, very careful dissection energy so that it has a very soft effect on the tissue and is not very disruptive. Okay, and this is how you get the mastery of a nucleation. You have to know how to use the energy, what distance, what speed, and of course, where do you target the energy. So you see, for that, the coagulation of the vessel that I just did, I was using the same pedal, but just I increased the distance to get a coagulation effect. And here you see that the fiber is aiming constantly towards the upper part, towards the adenoma, you see, so that the energy is not coming into the capsule. It's more on the upper page of the book, you know, if you know what I mean. Here we are seeing that the capsule gets very, very thin. Okay, so instead of panicking, you know, you try to avoid making it deeper, making it worse, and you keep the fiber closer to the adenoma. So I'm a little bit repetitive, but I think this is one of the most important aspects of enucleation. And there we are. That is now the attachment at 6 o'clock. You see, sometimes these areas are quite sticky, and here again I keep the fiber close to the side of the adenoma to make sure that we can continue the dissection without deepening and trying to complete the procedure. You see, it's now 27 minutes in the operation. So, you know, it takes what it takes. I'm not, you know, competing for speed. But of course, if you are able to work continuously, or let's say work most of the time, if you don't hesitate too much, then you can progress very fast and try to complete these operations. Often at the end, we are going to see that we are nearly undermining the bladder neck. These things, if you can keep them, let's say, reasonably deep, you know, if you don't go too far, they have no consequence. And that's how you adapt to a difficult case, trying to use, of course, a surgical strategy that we all know. You know, if you do an in-block technique and the early apical liberation, you follow certain steps. But of course, we have to be conscious of the surgical principles of how to use a laser, how to modulate the effect of the laser, you know, how to make the most of the settings that you have chosen to. I'm sorry for the noises. It's my daughter sending messages, so she's very communicative, and I will reply right after the finishing of this video. So there we are, trying to finalize the posterior dissection, always keeping, you know, that's another, you know, subtrigonal nodule. You see that? This is a big nodule here. I keep my laser up. There you see, to try to stay and leave some capsule or some capsular elements. Of course, the fossa is now very distended because of the pressure. The moment we put a catheter, all of this is going to collapse, and I think all these fibers and things are going to stick together, and there will be an inflammatory process, clot formation, all these things that will allow the capsule to heal very fast. Usually we remove the catheter the next morning, the following morning, except if there is a very deep undermining of the trigon, which is not very usual. Sometimes it may happen, and then we might decide to keep the catheter for a couple of days rather than just one day. And that's reaching to an end. In many instances, we can elevate the lobe and flip the adenoma. Sometimes we flip one lobe first, sometimes it goes in, and here at the end, sometimes I find it easier to use the fiber at 6 o'clock. You see, that's the UO. So we are okay, and if we go to the other side, check for the bladder neck. That's the UO on the other side, and now we can finalize the liberation of the 6 o'clock attachment, trying to follow the curvature of the bladder neck. Some people do incisions in the bladder neck after removing the adenoma. I think in this case there's already a very good depth, and you see we have managed to get into a very very good capsular plane. We are sure that there's no remaining adenoma, and now of course I have to do hemostasis. If you get deeper, in a certain region, you might find that the bleeding is a little bit more. When you find a very beautiful plane and you follow that, this surface has very little tendency to bleed. But when you go into a slightly deeper area, you might find that there's more bleeding, and also more, I don't know how to say, more unpleasant, I think, to find venous sinuses, because venous sinuses are difficult to coagulate. You see big veins, probably the patient is absorbing some saline into the bloodstream, and that's a situation that is better avoided. And if it happens, it is going to complicate the morcellation phase as well, because if the pressure in the bladder falls, when you have a venous sinus open, the visibility is going to be compromised. So often, if you see a venous sinus, you can try to stop it by using the rolly ball and the resectoscope and the rolly ball, or if you have a big electrode, sometimes this is helping a little bit more. And we have to try to master this procedure so that we don't go too deep, and we don't see these sinuses, because they make things a little bit more difficult, and especially morcellation, I would say. And also they put the patient at risk of absorbing liquid and having consequences from absorption. So I tend to look at the saturation of oxygen of the patient, because one of the things that you might notice when the liquid goes into the bloodstream is that there is some, hypervolemia, and maybe there's a chance to develop pulmonary edema or rigidity. So that I look at the saturation of oxygen on the monitor of the patient, and if he's saturating really well, because you can continue more or less safely. Sometimes we lower the height of the irrigation bags, trying to, keep the pressure as low as possible. These are the things we have to tackle. If morcellation becomes impossible, it is always safer and better to put a catheter and come back to morcellate, maybe 2, 3, 4, 5 days after, when the tissue has already been, very soft and so these are the things we have to tackle. Interestingly, that little perforation with some fat visible was not relevant. It was too small, and probably the way that I went below left a little flap of tissue that probably, I was even looking for it, I think, at the end, and I couldn't really see where it was clearly. So it was a very, very small intraoperative situation that I was able to manage. Here you see that I'm being very, very careful with hemostasis. Normally with these pulse modulated lasers, you tend to have much better coagulation than what we had before. But occasionally, well, especially when the plane is difficult, we might see that there is, still a lot of bleeders, and we have to spend some time coagulating to be able to stop the bleeding and see properly during morcellation. Here I'm using different settings, although I coagulate sometimes with the same 2 joules 50 hertz setting with virtual basket, just by separating the fiber a little bit more. But when you use high power and the capsule is very thin, I'd rather use 1 joule and probably 40 hertz, something like that, because this is a much softer effect, and it's a little bit slower, but it provides a very nice, and I try to use a very long pulse or the bubble blast setting, which coagulate really well. And of course, we have to pay attention to the mucosa. Holmium cuts in a very disruptive manner. So that's a UO. So when you cut the mucosa, it's a very rough cut, so not always you can get good hemostasis when you cut the mucosa. And the mucosa sometimes is well inside the bladder side of the bladder neck, and if you don't check it, many times you start the morcellation and then you see that the visibility is not very good because you left some small vessels like the ones you have just seen at the bladder mucosa edge that are going to make our life difficult with morcellation. So spend some time doing morcellation, especially when you start with HoLEP, because I have to say, with practice and with experience, you can morcellate under bad visibility conditions. I put the tip of the morcellator on top of the bladder neck, I separate from the bladder, and often even with relatively bad visibility we cannot morcellate safely. But of course, this is one of the dogmas of morcellation. You should try to have the best possible hemostasis. If you don't get good hemostasis with the laser, go in with a resectoscope and pass the rolly ball to get the best possible hemostasis. Here I am changing the instrument. I'm going to use the morcelloscope or the nephroscope to be able to introduce the blade, and I will start the morcellation. So you see, I put the morcellator inside. Usually you have to focus the camera to see a little bit better. You see that I was not able to coagulate the mucosa there perfectly, but here now I have the morcellator in a safe position, 2 or 3 centimeters above the bladder neck, and see how I keep the blade a little bit inside so that I can see 2 black triangles on the sides of the blade that tell me that I'm far away from the mucosa. And with the Piranha morcellator we have a reasonably good morcellation rate of about 11 grams per minute, although morcellators tend to be temperamental, and some days they work better than others. Also, the tissues sometimes are very hard compared to other tissues, so we see some variability in the quality of morcellation. What happens almost always is that during morcellation the visibility is going to decay, unless if you do a perfect hemostasis, which is not always easy or achievable, and that's why you need a relatively fast morcellator. Now there's a lorry coming around my house, with loudspeakers. Maybe you got that. which is going to stay there forever. And so there we go. I really am quite happy to receive so much feedback from people who find that these videos are helping them to do HoLEP and learn new stuff, and I'm very grateful and happy that all this effort to prepare the videos and discuss them and so on is helping people out there. I met one guy in Buenos Aires. He told me that he had been left by 3 girlfriends because he was staying late at night watching the video. So I was very sorry for that. But yeah, I think, you know, HoLEP is really a wonderful operation, and it's important to keep training yourselves to be more efficient. It's important to try to improve and maybe leave your comfort area, try new things, you know, because if you can master this procedure, you're going to make a lot of patients happy. You will have very low stress incontinence rates, and if there is incontinence, it's going to be mild and very, very fast. You know, it will disappear, and you will make a very, very high proportion of your patients happy by, you know, the development of your skills. Also, I think being effective and doing faster operations reduce the stress on the urethra. So yeah, I think it's always a learning process. I have to say that I still learn a lot, you know, every week. It's now, I think this technique, the Bloc technique with early apical release and the preservation of the apical mucosa is now very well developed. You know, it's quite mature. We could change or modify some of the, let's say, steps, but not this apical dissection so much. I think the apical dissection has been very well standardized, and you know, maybe you can open the bladder neck a little bit earlier and then complete the lateral and posterior dissection, or you might try to make a better dissection of the lateral and even posterior before opening the bladder neck. These are optional things, I think, that everybody probably will make different, but there's always new challenging cases and new, you know, situations where you have to test yourself. And I have to say, if you stick to the basic principles of how to use the energy, especially recognizing capsular deepening and modifying your line, you know, so that you get closer to the adenoma to prevent deepening even more. If you use a soft energy for dissection, if you are organized in your steps, you know, so you know the basic science, the basic principles of how to use the laser, and then you follow a sound strategy, carrying the lines, connecting the lines, so you have a good reference of where you are, then it becomes a very affordable procedure and also very fast. So we're coming to an end. I think this is now finishing the morcellation, and again I would like to thank you for all the positive feedback. It always makes my day, you know, when someone says thank you, you know, your videos help me a lot, and I keep encouraging you to learn, to do HoLEP. If you don't have the money, you know, steal it. Get yourself a laser, get yourself the instruments, get yourself a good camera, and start, you know, start, because you will help a lot of patients and they will be very happy and grateful. So let me know in the comments if there's something you want to discuss or comment, and I will be happy to reply. And if you want to come and visit us sometime, get in touch, reach out, and we'll see what we can do to help you. Here, you know, we have these small buckets for the water in Bulgaria. So we can do a fast change, but right at the final moment, you know, we had to change because the bucket was full. So this explains the little pause, and then I will try to capture the last little bit of tissue before coming out. There it is. Okay, so that's the end. Thank you very much for your attention, and all the best.